Also for completeness, though it does have a limited role, in my opinion, in the emergency department, is the use of regional procedures, whether you're looking at regional nerve blocks, epidural or spinal anesthesia. And that is because of a couple of things. So firstly, the time that this takes in order to get to these patients, the amount of post-procedure care that these patients will require in addition to the reason that they are having pain at the time, but also due to this often a skills deficit on a 24-hour basis in an emergency department. All right, let's talk about the drugs. Let me pull out my drug dealer cap and talk about the drugs. So I'm going to start at the bottom of that WHO pyramid, and let's talk about paracetamol. I think it's probably one of the most underused analgesic agents that we've got, and now particularly that paracetamol or acetaminophen is available in intravascular forms. We are able to get a rapid loading, a good duration of analgesia, and a very good level for the patients. One of our patients recently described the effect of this intravenous paracetamol, of the pain melting out of them without disturbing her thoughts. And I thought that was probably one of the best descriptions I've heard. We know that paracetamol is thought to work as a cyclooxygenase inhibitor. It also has a central antinociceptive effect, though that mechanism is not well established. It also has antipyretic agents or activity, so that is of great benefit. We see that it has a rapid onset, particularly if you've used the intravenous approach, though we do get significant blood levels after 1 hour, even after an oral administration. Of course, it's not without its problems. You do reach problems with the toxicity, particularly hepatic. And I think we've all had that scenario where patients either willingly or unwillingly have taken large amounts of paracetamol, and the potential hepatic toxicity that can result. And so the recommendation is not to exceed 4 grams per 24 hours for an adult, and if the individual is less than 50 kilograms, not to exceed 60 milligrams per kilogram per day. The non-steroidal anti-inflammatories, again, are used extensively, particularly in musculoskeletal injuries, and have great effect, particularly when used in conjunction with paracetamol. They too are not without their complications, and whether that is with regards to gastrointestinal side effects or effects on platelets, we do need to acknowledge that they are significant, they are used significantly, and many of our patients will have already used them because certainly in many countries the non-steroidals are over-the-counter medications. All right, let's talk about the good stuff, the stuff that comes from the poppy. How many people here have actually been on the receiving end of opiates? So it's about 10% of the room have been on the receiving end. Did it feel good? I'm getting, now this is getting interesting. So now we were at a 1/3 saying it felt good and 2/3 saying it felt bad. And this is the hit and miss that we often have with the opiates. Yes, they are potent analgesics, but often the complications and the side effects from them make them unfavorable for the patient populations that we are wanting to treat. What we do know with the opiates, though, is that they have activities across many receptors, particularly within the central nervous system. They also influence the emotional aspects of pain, and to some extent may reduce the anxiety that patients often have, though that reduction in the patients being able to speak for themselves, to fully comprehend what's going on, can be problematic. Now, Generally, we tend to use the intravenous forms. So the two that I'm going to mention are the ones that we use most commonly in the department that I work, that being fentanyl and morphine. Fentanyl is a very potent synthetic opiate. It is very effective and has got a relatively short half-life compared to some of the other opiates. The other benefit is that fentanyl tends to be relatively hemodynamically stable compared to some of the other opiates. From a dosage perspective, we're looking at a 1 mic per kg, and you can repeat that up to 3 mics per kg, and your duration of action on the intravenous form will be anything between 30 minutes and 60 minutes. So it's great for short-term analgesia, particularly when you're needing support around a procedure that you may be doing. Morphine, on the other hand, is probably one of the oldest opiates that we have in our arsenal, and the reason that it's the oldest is that it generally does work. It's generally cheap, and generally people are familiar with it, which makes it a safe drug to give. From a bioavailability perspective, it is immediately available and has a half-life in the range of 2 to 4 hours. And the last group that I just want to mention is something that we use quite a bit, and that is the beautiful green whistle, being penthrox or methoxyflurane. I did check on the Turkish formulary before I came here that it was available for it. Is available here. Can I just understand if anyone uses methoxyflurane? I'm getting shaking heads. Methoxyflurane was initially developed as an anesthetic agent. It was withdrawn from the market because of hepatotoxicity at that stage, but it was reintroduced as an analgesic agent. It is patient administered, so they literally hold on that whistle and they suck on it. And when they lose their faculties, they are not able to hold on to that whistle any longer, so they don't get any more. It's very effective. It's used a lot in pre-hospital medicine, in that it is relatively hemodynamically stable and provides good levels of analgesia. And we even use this for the closed reduction of fractures. It is so effective. I think the important thing that I want to establish is that combinations in analgesia in emergency medicine are important. So combinations of things like paracetamol with opiates will certainly not only lessen the amount of opiates that you are needing to give, but also the need for opiates at all. And remember that little old lady that you really don't want to give the opiates to? Think of IV paracetamol. To conclude then, I just need to say that there are 3 aspects that we need to be familiar with when we're talking about pain and analgesia in emergency medicine. We need to have an objective assessment of the patient's pain, and that is best done by the patient themselves. We need to look at what type of pain that the patient is facing so that we can address our agents accordingly, and then select the agents appropriately using that WHO ladder. For those that are interested, there are some fantastic reading materials that I do recommend. USAM brought out recently the guidelines for the management of acute pain in emergency situations. The Royal College has done something similar, and I've seen a large amount of publications coming through in the Turkish Journal of Emergency Medicine of late, looking at the practices of administration of analgesia in the emergency department. Again, some other fantastic articles that I would recommend. But really what we want is that and not sounding like that. And with that, I thank you for your time.
Thank you, Dr. Dickerson. There's room for one question. Yes.
Hello, hi. Thank you for this speech. It was like, I love it. So I just want to ask about the combination between like paracetamol and opioid. Can you give
I'm just
more?
going to come to you on
I just want to ask about the combination between with paracetamol and opioid. Can you give more? Which is the what do you prefer to mix? Because like I do it at the emergency room we have back in my city, and like the patient love it. But like the old teacher there, they are against it. Do not like use opioid so much with the patients. So can you give me a lot of information about it? Thank you.
So just to make sure that I've got the question correct, we're talking about when we are using that IV paracetamol and in conjunction with things like opiates, how do you go about that and which agents do I particularly use? Perfect. Okay, so firstly, always start with the IV paracetamol. We know that it's going to have a bit of time before it gets up to therapeutic levels. But also it's going to give you a better idea of how much and how potent an opiate you are going to need. So administer the IV paracetamol and do that religiously every 6 hours so that you're giving that 1 gram every 6 hours. And it gives that very good baseline analgesia. Generally on top of that, I don't go with fentanyl. I save the fentanyl for the short-term analgesia that I'm needing for around procedures, whether it's relocation of joints or reduction of fractures or insertion of intercostal drains and those kinds of things. I tend to use morphine. Now, I particularly don't like using intramuscular morphine. I much prefer that it is administered intravenously. I think we get a far better idea of dose response, and we can get away with lower doses. And so with lower doses, lower ranges of complications and side effects. So we will start with 2 to 4 milligrams. I don't do the anesthetic load as my colleague sitting here from anesthesia, so we don't go at the 0.1 milligrams per kilogram. That is suggested as the starting dose. We go lower, but reassess frequently every 15 to 20 minutes, and then give an additional 2 milligrams until you've got to the level of analgesia that you're needing. Has that answered your question? Sure.
I'm just curious about, like, you know, when you are at the emergency room and, like, you know the patients from their appearance, and you know this patient will not be, like, satisfied by just paracetamol. So do you, like, give them the mixed, like, paracetamol and opioid at the same time, or do you not prefer to give that?
So generally, I don't give them at the same time, but I tell the patients that it is available if they need it. Because I think if you tell a patient that they're only getting a gram of paracetamol and that's going to be their analgesia, that anxiety portion is going to have great effect. So I'm very honest with them, and I say, we've got a stepwise approach to your analgesia. We start broadly, and then we work to more specific agents. And we want to give you the lowest amount that is necessary to manage your pain adequately, and you will tell us when that pain is managed adequately.
Thank you. Thanks so much.
Great. Thank you very much, Doctor.
Thank you.
Thank you very much. We have now our Professor Isa from Ankara at the College of Gazi University, and he's going to talk about syncope. Thank you, Dr. Isa, for your readiness and preparedness, charisma of a true emergency physician.
First of all, I would like to thank to my moderators, professor, and also to my audience. And also I would like to give special thanks to organizing committee of APATS for this lovely congress. And after the very good, great, fantastic presentations presented by Professor Dickerson, I would like to give some mysteries related in the emergency department, the syncope patients, and how can manage in these emergency settings, who needs admissions, and I would like to give the syncope risk score and also validations. First of all, I would like to give a brief introductions with the syncope definitions and also the importance related with the ED management. As you know, the syncope is defined as a brief loss of consciousness due to global cerebral hypoperfusion with an spontaneous and complete prompt return to the basal consciousness level without any interventions, as you know, and is then like an light off and light on phenomenon. And it's all of the syncope patients about consist of 1 to 2% of ED visits. And as you know, the admission decision is problematic in the ED, which patients needs admissions or which patient should be discharged after the evaluation of syncope patients. There is an controversies and some complexity in the ED. And we need and also develops many risk stratifications, but the main goal, not the diagnosis. You should decide for the risk patients. And as you know, some of the life-threatening disease or condition in patients presented with the syncopes should be identified, especially, you know, dysrhythmia, arrhythmia, and pulmonary embolism, aortic dissections, subarachnoid hemorrhage, and acute coronary syndromes presented to the ED with the main symptom of syncope. So after this importance of the syncope patients in the ED, we are following the main guideline for this one. As you know, 2018 ECG guidelines. I will give some small summary. After that, we can give the syncope rules for this one. As you know, the 2018 ECG syncope guideline, firstly, you should define the syncope and you should give a differential diagnosis with the seizures, epileptic seizures, especially for the unwitnessed syncope patients. After then, you should get the initial syncope evaluation, basically history and physical examination. After then, you will get the blood pressure, and also first EKG evaluation should be started at the beginning of the evaluation of syncope patients. If the diagnosis is certain, no problem, go away, start the treatment. Because besides the syncope complaint, there are maybe another symptoms, so you can easily diagnose the patient. But most probably, when there is an uncertain diagnosis, you should go to the risk stratifications about the 3 waves: high risk, low risk, or moderate risk, maybe you do. And after then, these one, if the syncope predominant the reason for ED presents, and another complaints, if there's another complaint, maybe, you know, syncope is the another symptom, so go away for the differential diagnosis of these complaints. But if the diagnosis is uncertain after the initial evaluation of the syncope patients, if there's a no, I'm sorry. Appropriate therapy appropriate therapy is appropriate, but if there is no diagnosis, only the symptoms of syncope present, you should go risk stratifications. And after then this one, I'm sorry. And there's the risk stratification starting from the history taking and past medical history, low high risk, as you know, and you perform physical examinations especially for the cardiac examinations and blood pressure. And after then, you should take the first initial EKG and you should look for any pathologies related with the syncope. And there's a low and high risk for these initial EKG evaluations. After all of these evaluations, you should put an risk stratification, and according to these evaluations, if the patient is low risk, then this patient can be discharged, as you know. But for the high risk and for the moderate risk, you should either discharge the patient or should be admitted to the hospitalizations. And before starting this certification, I will give a special case presentations. Please remember the case, and maybe we can discuss whether you perform a risk certification according to this one. Imagine a patient coming from the celebrate, on a warm, hot weather, summer evening, while celebrating his son's wedding on Saturday. At 72 years old man, patient admitted to the emergency department with ambulance, and at late midnight, after syncope attack, the father, dancing so much, and hit somewhere else, like that, and then syncope, and so many people outside the ED waiting your results. What will you say? Either you will discharge or you're hospitalized, so they are waiting for you. And I would like to give your opinion. Do you think these patients should be admitted or can be discharged? I will give another information about this one. He vomits one time and no other symptoms. No chest pain, no dyspnea, no headache. And when he arrives to ED, the physical examination completely normal without any complaints. In his past medical history, he has known coronary artery diseases and LAD standing 5 years ago. He has also hypertension, and he is using their medication for the coronary artery diseases, coraspin, beta-prolol, and atorvastatin, also ACE inhibitors. On arrival, the vital signs somewhat normal. There is no bradycardia, somewhat blood pressure higher, a bit higher blood pressure, and the pulse is 97%. For these patients, would you like order another test? Yeah, the first EKG. I will show some higher mortality rate EKG for this one, but assume that this EKG with a normal sinus rhythm without any ST wave change. And now, what about your decisions? Is there anybody decides this patient can be discharged or admitted or somewhat? And because there are so many people outside ED, they are waiting for your evaluations. Is there anybody, what do you plan? Do you want to, is there anybody directly discharge these patients or directly admit to the hospitals in the cardiology units, for example. Let's look at the patients. These are some special samples from my own EKG samples. Some important high mortality syncope patients. Can you diagnose this one? Okay, as you know, V1. These are the Brugada syndrome, the 24 years female patients, isolated without any prodromal complaints, isolated syncopes patients. Another else is then the patient with an arrhythmia, as you see, ectopic atrial rhythms, nodal rhythms. Also, maybe you can see this one. I'm sorry. As you see, ventricular tachycardia after syncopes. Okay. We couldn't see any of these EKG findings, but there's an assume that the patient has normal EKG. And I would like to talk about the syncope risk scores and their validations. There are so many, several examples of syncope risk scores coming from the 1997 until now. There are many risk scores, but I searched all of the literatures and I found most important rules. Okay. And I prefer to order from the years by years. Okay, the first and famous one, OSL scores coming from the Italy, which was published in 2000 and 2003. And the second one, the most famous one, San Francisco syncope rules. And third one, Boston syncope rules. And the Rose one, Rose syncope in the emergency departments. And EG SYS, evaluation of syncope guidance syncope study. And the last one, the Canadian syncope risk score. I don't involve the other scores because these are the most of the main and important ones. In your routine, in emergency departments, which score or which certification rules do you prefer? Is there anybody who can give comments for this one? Huh? Canadian. Why? Can I get the answer? Why do you prefer Canadian ones? Yeah, that's done most validated and most comprehensive. It's a very good scores, and especially for the higher level of EDs, the standard care for the syncope patient, the Canadian syncope risk scores. And now, what about the others? Is there any other risk score routinely used in your ED? San Francisco. What about? Yeah. Yeah, probably most of the ED preferred to use Canadian syncope risk score. And I will give all of the information about this score, which was superior, which was inferior, by comparing the other scores. The first one, OSL scores, coming from Italy, that evaluates the 12 months all-cause mortality and aiding in the long-term risk assessment. And the San Francisco syncope rules keep. When we are in young men, all the time our professors ask these ones. San Francisco syncope rules is a very famous one. It's done very quick and simple to use. But, when you when you look at the validation score, validation studies, there you will see the poor external validations and inconsistent performance limit. It is reliability. And the third one, the Boston syncope rules, is consists of about 25 criteria. It's a derivation of ASAP policy, San Francisco Discover, internist and the intensive care unit policy that are very good for the high sensitivity with a negative predictivity, but there's so much more criteria and difficult to remember when you evaluate for the evaluation of syncope patients. The ROSE, I think coming from England, right? United Kingdom. I will give the information about this. This also predicts 1 month service outcomes and death in patients with syncope patients. EGS-wise score also is a more superior for the cardiac causes of syncope patients. It's a bit more superior for the cardiac etiology, and the Canadian one, the most compressed and well-validated score for all of these one. But when you look at the literature, all of these syncope rules and the others literature review meta-analysis, clinical guessed is more superior when you compare these syncope rules. So ECG explicitly cautioned that recertification score performs no better than good clinical judgments. It's very important and should not be used alone to perform the risk certification in the EDs. And let's look at some criteria for the specific risk score. The OSS score for 2001, it shows 1 year mortality, and it consists of 9 criteria. But as you look at this one, the older patients with this one, okay, and literature, okay, and also, you know, as you see, syncope patient and with a high mortality, and it's used for older one, and newly developed syncope scores may be coming from this one. And there's and the most famous one that I would like to talk about is San Francisco syncope rules. It's a very good mnemonics with the name of CHESS. Very, it can be remembered easily with a high sensitivity in the specificity in the original study, but later validation studies decrease the sensitivity performed by the Queen, and validation studies very well done for the San Francisco syncope rules. And the CHESS, as you look at for this one, it differentiates the syncope from the cardiac and non-cardiac, especially reflex syncopes rules. And it has been evaluated in validation scales Sun and Birmingham. Okay. San Francisco syncope rules have a very good idea. It's one I prefer this one. And Boston syncope rules, some words, most words. So these are so many criteria. It can be, it's very difficult to remember for this one. So I don't prefer the Boston syncope rules so much, but it's a very high sensitivity when you compare the San Francisco syncope rules. It's a derivation from the ASAP policy. And rules is a very another sufficient rules, but there is no validation study for this one. Also, it includes the BNP evaluation for the syncope patient. It's not available for all the time for the syncope patients. And let's look at this one. And the ECG one is also other ones for the cardiac cause effects. The last one, the Canadian syncope score, is the best one, the best validated scores all the time. But there's some questions about the Canadian risk scores because there is some minus and plus scores for this one. Also, there is a discussion about the diagnosis in the emergency departments. So it's then used somewhat difficult for the ED evaluation of syncope patient, but it's a very well validated score, routinely used most of the ED patients. Okay. And then I will give so much scoring this one. And for the last few minutes, I would like to give high-risk admission criteria for these variant admissions, the cardiac etiology.
We have 1 minute only.
Clinical instability. Conclusion is the lowest one. Physician Gesselt is very high sensitive and making clear limitation ones. And why I prefer to use San Francisco syncope rules because it's very logic to apply these patients. This one, please take home points. Risk certifications such as the Canadian syncope risk score helps identify the low-risk patients safe for discharge, and why clinical judgment and clinical gestalt remains critical as it in 100% sensitive. Thank you very much and for your patience.
Thank you, Professor Isa. We apologize for the audience if we can postpone the question to after the last session, if you don't mind. Thank you.
Thank you very much.
And then we have the next speaker, that's Michael Prook. He's an associate professor at John Paul II Catholic University of Lublin.
Hello everyone, my name is Michał Prúc. Okay, we have it. Today I want to talk about completely different subject from my previous speakers because I want to talk about the simple counts to powerful insights and the role of hematological ratios in acute coronary syndromes. Like, it might be something really simple, but we can use it and get a lot of different information from that. So, first, why there matters? They matters because, like, we have the inflammation, which is also the part of the disease in acute coronary syndromes. We know that, like, the plaque ruptures and thrombosis starts, immune cells and platelets also react. We know that neutrophils and all the immune cells are getting high during this immunologic response. The lymphocytes often goes down because of the stress. Monocytes are also involved in plaque biology, and platelets reflect the thrombotic activity. So these reactions are interesting because they're combining two parts of the story at the same time. And how you can see on the slide, for example, we can use NLR, so the neutrophil to lymphocyte ratio, or platelets to lymphocyte ratio, or monocyte to high density lipoprotein cholesterol ratio, and we can take a lot of inflammatory or other mechanism during that process to see more of what's happening with that patients. Of course, these ratios are not magic. They don't replace us the casual tests like troponin, ACG, angiography, or Grace or TIMI scores, or even our clinical judgment. But when the patient comes, we already have his blood. So all the stats are available on admission because we only use the calculations from mathematical formulas. So we can just put it to our blood tests, put the mathematical formula, and calculate all this from single blood tests. So the results arrive early with all the blood tests, and often before the whole picture of this patient is stated. We don't need extra cost because we are still doing the simple blood test, and we can add lipids to get more information about like the cholesterol. It's reproducible enough at the bedside triage, and we can integrate a couple of biology direction instead of having just the raw count of neutrophils. So we can improve like exactly the Grace score or predict other things that I would say in a couple of minutes. So what's good in their use is that we have early risk framing supporting prognosis after like PCI or even just after patient arrive. We can predict no reflow or minor acute cardiac events or even like heart failure risk. The best use is when we try to diagnose with that ratios and ignore other things that going on with the patients, like when the patient get infection, use steroids, have cancer, or have chronic kidney disease or frailty or other symptoms, because as we know, all these illnesses could rise, for example, neutrophils or other parameters in blood. Right now we have a lot of these ratios. Like, in my opinion, I get all of the newer ones and the most important ones that there is studied right now. So as you can see, it's just the single mathematical formulas from the blood. We have neutrophils, we have platelets, we have monocytes, lymphocytes. We can gain like MHRs with cholesterol. SEE is more difficult because it's multiplying platelets with neutrophils and divided it by lymphocytes, but now a lot of studies is into that. SERE, the same thing, and many other. And now I want to talk more about them. Like, the most studies which were made is in neutrophil to lymphocyte ratio. It has the deepest evidence base, tracks both acute inflammation and stress lymphopenia, work across diagnosis, phenotype, severity, and prognosis. It's cheap because we don't need any other cost of the parameters, and it's not perfect. We done the study, a meta-analysis, which was compared from 90 studies, included almost 46,000 of patients. And as you can see, we can different STEMI from like unSTEMI patients or unstable angina or just like healthy volunteers. And we can also like see that we can predict minor acute cardiac events or use it to prediction of other things like for stent thrombosis, which is also in mice. The same thing, but we have less trials on that, is the plated lymphocyte radio. Also, we prepare not so big meta-analysis that for NLR, because like in this meta-analysis we use about 18 studies. And we also could predict mice with it, the no reflow, impaired coronary perfusion, and with this parameter we can also like see the role of the platelets with this thrombotic story of this subject. And it's, as you can see, what is right, that it's less universal than neutrophil to lymphocyte radio. Another one is MHR, so the monocyte to high density lipoprotein ratio. And it is interesting because it connects the inflammation with the lipid side of the story. And the monocyte represents this inflammation, and this cholesterol is a part of anti-inflammatory and protective story. So we compare two different things. So biologically, this one makes a lot of sense. It is especially nice when we talk about like plaque biology and residual risk. And evidence on that is much more or less than NLR and PLR, because like when we want to get whole data on that subject, we only found 11 relevant studies, but still like higher MHR was may improve the in-hospital and long-term cardiovascular risk prediction. The same thing with new parameters like monocyte to lymphocyte ratio and lymphocyte to monocyte ratio, because in studies they use it differently, but it's quite similar. These parameters seem to have the real value. Like in general, higher MLR is associated with worse outcomes, and lower LMR also points in the bad direction. So the signal is there. But when we compare it to NLR, the evidence is less mature and less consistent. So we can only like try to make more data on it. SE, or the systemic inflammation index, is probably the strongest next step after the simple ratios. It combines platelets, neutrophils, and lymphocytes. Because of that, it feels closer to the real biology of acute coronary syndromes, where inflammation and thrombosis happen together. In some studies, SE predicts poor outcome better than NLR and PLR. So this one is the more impressive component marker than all the beginning one. Here. And the other one is SERE, which is also very interesting. This marker uses monocytes instead of platelets, so it leans more into other inflammatory biology and remodeling. Some of the data here are quite strong, and one important study showed that SERE added prognostic value on the top of the GRACE score. That part is especially important, but the limitation is simply that evidence base is still much smaller than other scores we have. We also have another ratios, but here there is not a lot of data on that, but everyone tried to connect this ratio with prognosis in ACS. So it also show real signal, also is about inflammation. It works quite same, but the data is totally different from the previous ones. The cutoffs of these biomarkers varies a lot, and some of formulas different between the studies. So it's not easy to use them. They are not prepared for the clinical bedside use, and still we need more data on them. The same with PIF, NPR, and newer signals. Like, there are some other very new markers and also starting to appear in the literature. They look interesting, and some recent studies suggest their prognostic value, but at this stage we couldn't say too much about them, and I think they belong more to the future research than the current clinical role. So I would mention them carefully, but not say a lot of them. Which ratios right now look strongest? So in my opinion, we have the most data about neutrophil to lymphocyte ratio, so it would be on the first tier that we can try to use right now in the clinical use to predict exactly this maze, the prognosis of the patients. The next one, which I also say would be SEE, because it's the best supported composition of the markers in the blood. The second tier would also be PLR and MHR, because we have data which support it, and it especially gives us information about the plaque and the status of the patient who come to our department. The third tier would be SRE, because it looks very promising and may be more important in the future. And the other biomarkers still needs validation, a lot of data. We are needing to finding the cutoffs of it, or even prepare the right formula, mathematical formula to make them proper, because like I said previously, many of the studies have totally different mathematical formula to use them. And how I actually use them in practice. We can use it on admission, after PCI, with risk scores. Also, the studies are measuring them 24 hours after admission, 48 hours after admission, up to 72 hours after admission. And in each of these hours, it could give us completely different situations, how the status of the patients is changing. They are also changing. But the same as with the tier table, I would put neutrophil to lymphocyte ratio the highest. I would not use them as something universal, because we still need the proper cutoffs for all of them. We couldn't ignore the status of the patients with their infection, bleeding, or frailty. They would be the most helpful when added to risk scores, when added to the clinical view on this patient, and to predict just the outcome of the patients in the future, or the major cardiac adverse events. So the common problems with the studies on that biomarkers is that most of them are single center design. They have different endpoints with the maze. They have different blow draw timing, the cutoffs, and the confoundings of the patient. We have many methodological traps that many of these radios are not independent. So the field is moving to the right decision, but it is not finished. So we still need more data on these ratios, but in my opinion it is easy to gain because we don't need any more money to give that information. So this is my take-home message. Like I say, neutrophil to lymphocyte ratio is right now the safest overall bedside ratio. LARA is useful mainly when conversing and drifting towards thrombotic burden. MHR is one of the most appealing inflammatory lipid hybrids. SE is probably the strongest broadly supported composite marker. Most newer indices are promising adjust, but won't replace as the grace troponin, ECG or clinical judgment. And thank you.
Thank you very much for your presentations. Are there any questions to all three speakers? Yes.
First of all, I want to thank you, Dr. Michael, for this great presentation. My question is how to decide which score should I study in my research. For an example, if I have an appendicitis data set, which score should I study here? What do you recommend, for an example?
Like you can also make all of them, but at one time. Like right now we have the most information, the most preferable cutoffs, so we know what cutoffs can mean what with neutrophil to lymphocyte ratio. But if you want exactly like to study these ratios, you can like do all of them at the same time, because why not? We still need a lot of information on that, so we can compare like neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, MHR, or all of other biomarkers to see which one is the best, which one we can use clinically, and which one could give us the most information on the patient.
Okay, thank you so much.
Are there other questions? Oh, yeah, over there.
Thank you. Professor Szachpak, maybe I don't have a question, but I want to add something. If you want examine some biomarkers, it's depending on the specific of the disease. And you should look for the specific markers according to the disease. It will be totally different for the ACS, for the cardiac arrest, for the pancreatitis. But if you have the morphology, of course, Michael showed you the several ratios, but you can create your own if you have such as data.
Okay, the room for the last question.
Thank you for all excellent talks. I do have a question for the first speaker. Do you use VR as a way to relieve pain in an acute situation?
So, We haven't, and I do work in a rather resource-constrained environment, and that was one of the biggest issues with the use of VR. But the fact that I can use VR in my home and escape from the pains of my life, I think it would be very valuable. But you seem to have a little bit more information, so I'm going to bounce it straight back at you. Can you tell us what you use it for?
We're lucky. We have VR available, not that as much as we would like, but we do have it, and especially for the small children, for the pediatrics, just for the short period of putting in an IV or something like that, and with good experiences. Thank you.
Thank you, Dr. Roger. I have a question for you. We're still facing the issue of the pain scale, all of them. Still, we have a big area of subjectivity. Sometimes the patient is crossing legs and playing with the mobile, and you ask the pain score, say 10 out of 10. So it's really annoying.
I managed not to fall, so that's a good start. I think that it's often we don't look at the background of the patient, because often you find the patients who have significant chronic pain will categorically underestimate the severity of their pain because they've got used to it. It's a similar thing we were chatting earlier. If I had fallen running up to the microphone now, and I'd bumped my knee, I would have got up and said, yes, I've got pain, but we carry on. Mainly because I would be embarrassed, and that embarrassment and all of that. But so I think that's the thing, is that when we are making that assessment, that pain history is probably one of the most important things to inform and help us to validate those pain scores. Because people who have not experienced pain before, that would be the worst pain that they have ever experienced in their life. So they can be completely honest, saying, yes, it's 10 out of 10, because this is the worst pain I've ever felt. They haven't had the heart attack yet. They haven't had the broken bone or the pancreatitis or whatever. They haven't had that severe pain. But understanding that our analgesia should be tailored towards the patient, we want to take that pain away from them. And if we are able to use those scales, but it's not a one-time shot, so we regularly apply those pain scales. And I do take your point, though, that I call it Durban beach position. It's when the patient has got both hands behind their heads and their ankles crossed. Generally, patients in Durban beach position do not have significant pain, but that also comes part of our assessment.
Can we have something like a median score between the objectivity and the subjectivity? So the patient will score something, I will give a score, and then we take a median.
So firstly, I look forward to your research paper on that, because whilst we do know that as clinicians, we underestimate the severity of pain, particularly in very severe pain. So we are very good for the minor pain. We're not great when it comes onto the severe pain. And so perhaps a combination of the two. But however, if we take that assessment approach by going through that history, and particularly the pain history, looking at what the current condition is and the type of pain that you're dealing with, and then taking into account the patient's assessment of that pain, perhaps that is the best idea. But I look forward to your scoring system, which will be out in 6 months?
You have to wait.
For next year's conference then.
Yes, indeed. Okay, sorry guys, but we really, really need to stop. So we can have the discussion during tea, coffee, and thank you very much. Thank you for the speakers. Thank you.
up in a way that if you all can move here, then we can all have you within our view. Did you get your mic? Your mic is coming. All right, so I'm so glad to see you all here. My name is Dr. Sagar Kalwankar. I'm from the Florida State University in United States from Sarasota. And let's go around and introduce ourselves as we get on with the beautiful concept which we are promoting is a discussion and open town hall with our delegates out here about various contemporary issues in emergency medicine and what's new and what are the challenges we face today and what are the opportunities we have for the next decade as emergency medicine evolves with the generation and technology. So we'll start with you.
Okay, I'm Dr. Lisa Moreno-Walton. I am a professor of emergency medicine at University of South Alabama, and I am professor of medicine at Louisiana State University, professor of surgery at Tulane University, past president of the American Academy of Emergency Medicine, and current president of ACAIM, the American College of Academic International Medicine.
My name is John Ma, and I am a professor of emergency medicine at Florida State University. I'm delighted to be here today.
Hello, my name is Łukasz Szarpak. I'm professor of medicine, director of the Transfer Technology Center at the Catholic University of Lublin in Poland, besides the vice director of the EMS in Warsaw and the president of Polish Society of Disaster Medicine.
Dr. Behçet from Istanbul University.
No, you don't. You have an extra mic.
Sorry about Dr. Behçet from Istanbul Medeniyet University in the emergency department. You are welcome. I'm also a member of board of the EPAD. Thank you very much.
Thank you, Dr. Bechet. So it's a very unique surrounding. So if we go around completely totaling how many years we have been in medicine after the time we graduated, practicing as doctors, we count specialty training as practice of medicine, but I think we are around 100 plus years. If we total the number of years we graduated from med school to the day we are practicing.
Easily.
So I think we have crossed over 100 years of experience in practice of medicine, and if we add all of you, then I think we have around 250 or nearly 300 years of emergency medicine or medicine practicing experience as physicians. So really we are standing on the crossroads of medicine as this, we just finished the first half of this century, and 25 years went back pretty fast, apart from the fact the political change and the speed at which politics changed in this last first half of the millennium. But as we look forward and we hope that we survive the next 25 years of this millennium, I would like to go around to ask you all from your looking back in this century. So I think the century changed drastically after 2000 with the technology boom and the fast-track technology boom and the change in the generation. Where do you see the last 25 years and what do you see in the next 25 years, Dr. Moreno?
Okay, so if I were to think about the last 25 years, I think one of the most important things is the rapidity with which technology has evolved. So I think about, I have been out of medical school for exactly 30 years now, and we did not have, in my medical school, we didn't have personal computers. We had mailboxes where we got all of our notices. We had to go into the histology lab to look at slides. So now I'm living in an age, right, where I have a cell phone and it's instantaneous. I think that that's also when I was in medical school, and again, like I'm old, but not that old, CAT scan was brand new. Emergency physicians weren't doing ultrasounds. The only people doing ultrasounds were radiologists. So technology has evolved very, very quickly, and I think technology is going to evolve much, much faster. The other thing that I think has changed tremendously, or what is a major development in the past 25 years, is the quality of research being done in emergency medicine. 25 years ago, emergency medicine research was not good. It was just not good. There was not a lot of evidence base. There was not a lot of people who had good experience in terms of doing study designs. And now we see things like the Surviving Sepsis campaign developed by an emergency physician, Emmanuel Rivers. We see the technology that's developing in critical care. Emergency medicine physicians are up there in critical care setting and developing infectious disease research, obstetrical research, public health research. So we are definitely making a mark on research. And so where do I see things going in the future? Again, I don't think there's anyone in emergency medicine who wouldn't say that AI is going to be a major, major issue in the next 25 years in terms of what we do at the bedside, in terms of what we do in research, in terms of what we do with technology. So I think both of those things, AI and technology, are going to continue to evolve and have a major impact on the way we practice. I am also hoping that there's a little bit of a drive right now to get back to some of the basics. A lot of talks here were about patients like being touched. They like being talked to. The importance of doing a physical exam and a good history. So I'm hoping that while we're advancing in technology on the one hand, on the other hand, we're becoming more human, going back to being more human with our patients and making a better connection with them.
Thank you, Dr. Moreno. Dr. Ma?
Well, I kind of divide things up into three categories: clinical practice, seeing our patients, teaching, and research. As far as clinical practice is concerned, the nice thing about the last 25 years and the next 25 years is we still need human beings to see patients. We will never be replaced. Unlike diagnostic radiologists who will be replaced someday, we will never be replaced because we need that interaction. It still comes down to taking a good history. More than anything else, taking a great history will help you as a physician 25 years ago or in the next 225 years, because AI can only take us so far. Garbage in, garbage out. You still need the precise questions from a human being to a human patient in order to delve into exactly what that patient might have. So if there's one thing I would stress to the younger generation is continue to work on your history-taking skills, because that is still the number one most important thing in emergency medicine. As far as teaching is concerned, I've really seen a dramatic shift from relying solely on textbooks to right now we have so many different options for learning, and AI will certainly accelerate that, but we have search engines that can help distill down things for us that we didn't have 25 years ago when we only had textbooks to read. We can actually study for boards using not only just a textbook, but YouTube and other things to help us with learning the material. So I think that's a very, very exciting process, and I think AI is just going to really help distill down things for us and make it much more efficient for people to learn, not only students, residents, but practicing physicians as well. And then as far as research is concerned, I think the biggest thing, at least from my perspective as a United States physician, is the funding for emergency medicine. 25 years ago, it was pretty scant. You know, we have what we call the NIH, the National Institute of Health, which is the major federal entity for funding research in healthcare. And that is sort of the gold standard in America for performing research and getting funding. And 25 years ago, it was fairly scant. Over the last 25 years, we've really seen emergency medicine start to capture a lot of great funding from the NIH. I know when I was chair at Oregon Health and Science University, we consistently ranked in the top 5 in the country as far as funding is concerned. And we had some star investigators who brought in millions and millions of dollars every year, and that helped pay for staff, for other things. So not only doing research will be important, but doing funded research is going to be the key. Thank you.
Lucas?
I'm in the best position because my previous speakers talk a lot, and I fully agree with Lisa and Joe that currently we have the increasing the AI in all life values, and in medicine is especially because right now we working on the big data, and the AI will help us, and this is for sure. We use AI even in the science, even in the learning process in the simulation centers, for example. We have OSCE, we have VR and others, so it's helpful. 20 years ago when I finalized my studies, we working by our local groups, and right now we can connect, such as during this Congress, connect people and perform in the international team networks. So this is also interesting because we can divide our suggestion, our abilities, our knowledge, precising and others. So I think in the next 25 years, the technology for sure will help us, and I fully agree that the AI never changed, never replaced emergency medicine, anesthesiology, surgery, maybe other specialization like a family doctor or something like that, or radiology, but we are safe. Thank you.
Thank you very much for this explanation. I just want to emphasize three very important to me. Many things, as it is mentioned, change. We have three missions as doctor. One is teaching, the second is caring the patient, and the third one is writing and searching. When we look at this, many of them, they change. I have been teaching for 18 years to the medical students and the residents. About 10 years ago, the students were watching your mouth. Yes, but now they are in front of us. We are running to catch them because they are much more smart than us, and they are very young, and they can reach by EA to the knowledge very well. They know language much more better than us. So and the patient also. The patient are not the patient in the story. Just before coming to emergency department, they are searching about their complaint from the internet or EA. So they are coming and they have different questions to you. They want to impress you. So they change also. The research and the paper, I just want to give an example. I sent the oral presentation to this Congress by simultaneously and studied an article. My article published, and I came here because they are searching in a very short way. Everything is very easy. When we look at the teaching, we have very important basic three steps. The one is knowledge, the second is attitude, and the third one is skills. The knowledge stop because everybody can reach it by himself or herself. So we have two missions now, skills and attitude. We have to care these steps very much. And this is the thing that our students and our residents are looking for us from us. And thank you very much again for the other explanation.
So, when you summarize what is being said, one common thing which came up in this first round of discussion was AI. And AI is a common factor when we look at it in the next 20 years or 25 years. So when you look at 2050 from 2025, from my perspective, I look at it in a different way. I think AI always existed, I think AI has been democratized to everybody. Our planes which flew in the air had AI even before its coming. So the fundamentals of autopilot, detecting or predicting weather, meteorology had AI before us. AI in NASA or sending rockets to the moon had AI before us. So I really think this is a democratization of a concept which has long been there. It is repackaging of a concept. So we are making more and more intelligent technology. Now we are trying to label it in a way saying that it is artificially intelligent and it's going to take over the brain, and I really think there's a lot of smoke than fire. And because you cannot only use technology with people who know how to use technology. So AI is not going to replace us. It is the people who use AI who are going to replace us. And that's very important. So the conceptually AI will never have a place. So a fool with a tool is always a fool. You still need to know how to deal with evolved technology. Initially, we used to have simulators which didn't have any instrumentation in them. They were just used for CPR. And we used to do the CPR with our hands. And now we have simulators which are multi-level, advanced, high fidelity, whatever name they give them. But again, you need a human to run that high fidelity sim to make sure that the calculations are correct and the readings are correct. So robots and AI are two different things. And now you talk about robotic surgery, we may get robots to put a central line too in the future, which is much easier than doing a heart surgery. And if robots become democratized and become cheaper, maybe that may be the future. So there's a big difference between AI, robotics, virtual reality. All this is evolution of technology. Having said that, when you talk about the generation is very comfortable with technology. Are they comfortable with working hard? That is a debate. So they are comfortable with working hardly, not working hard, because everything is available to them at a fingertip. It's not their fault. That's the way the world has evolved. You need a thing, you just press a button, within 24 hours you have it. There are countries like India where if you're cooking and you have something not missing in your kitchen, you can just press an app and within 10 minutes that thing is available to you at your doorstep. Anything in your kitchen, anything in your house is missing. When you talk about medicine, open access journals. So you look at last 25 years, we used to write an article, we used to get a revision, we used to correct it, you send it back. Then they used to charge us money. Then came open access. Open access came, everybody can read the articles. Then came publish before print. So the system has moved more and more faster, more and more, and they call it efficiency. So they are making our attention span shorter and shorter and shorter and shorter. And we are getting impatient slowly and steadily. So when I used to get an email, you used to answer an email about 20 years ago after a day or 2 days when you checked it. Now you get it on your phone, you just answer it quickly. So everything has become faster and faster and faster and faster. You check into a hotel, you don't need to. You just check in online and your things are ready, you pick it up. You go to the airport, your boarding passes, you don't have to stand in a line. So the technology makes it simpler, just thus eliminating humans and human factors through the system to make it techno-savvy. But the most important part is you still need humans to do the other part. So I look at it the other way, that do we need to have technology training for everybody, which is not there. So do we need technology's training for the next generation as a part of medicine? That's very important. Do the physicians of the future need to be technologically trained as creators, operators, sustainers, apart from just being general users? Your comments.
So I'm going to answer your question and then I'm going to raise another issue that I found very ironic when I was listening to you talk. So on the one hand, do physicians need technology training? I think the kids that are medical students and residents today grew up with technology training. You sit in the airport and you see a child who cannot speak yet, cannot walk yet, who's in a walker and has their iPad in front of them, and they're watching Baby Shark, and they know how to find the next movie that they want. And they can't talk and they can't walk. So I think they grow up with technology, and do they need specific training? I don't think so. Do they need specific training to operate the Da Vinci robot? Yes, they do, but not the kind of training that I would need, or that probably my colleagues here would need, who didn't grow up, with a laptop or an iPad in our hands when we were 18 months old. So I think it's going to be on a different scale. They're comfortable. They walk in and they know how to do the technology. They just have to learn the steps. But ironically, when you were talking, I could not help but think about the fact that you're talking about everybody wanting everything done fast, and yes, that's 100% true. But what has happened in our emergency rooms in our departments in the meantime? Nobody gets seen fast. Waiting time in the emergency department has increased astronomically. Beds have decreased astronomically. We're seeing people in the waiting room. We're seeing people in closets and in corners. Boarding has increased tremendously. The time that a patient is waiting to see a consultant has increased tremendously. So on the one hand, we're talking about everybody wants everything fast and everything's getting faster, but it's not. It's not getting faster. Information transmission is getting faster. I can get labs faster. I can get the patient's old chart and past medical history faster, but the patient is still sitting in my department for 17 hours because there's no bed upstairs. It's ironic.
I agree.
I think technology is great, and I hope it continues to accelerate and grow. I'm challenged by the use of technology as I get older. Fortunately, I have kids who can show me things, and they teach me how to use that technology, so that's wonderful, and then I'll have, and their kids will teach me as well. So I think technology is wonderful, but I think, Sagar started off with this as all these years of experience, and I can just say one thing. Looking back 30 years ago, I don't even recognize that person that I was back then. I would just encourage everyone to slow down. Everything is sped up right now. We even talk about the fast exam and ultrasound. Let's slow down. I would encourage everyone to slow down. When I became chair at Oregon Health and Science University, I succeeded a guy named Jairus Hedges, who is the Michael Jordan. He's the greatest researcher of all time in America. And this individual was amazing. He only slept 2 to 3 hours a night. He was able to just function for 21 hours a day without, too much sleep. So he would be answering emails at 2 o'clock, 3 o'clock in the morning. And that was who I was succeeding. So there was immense pressure on me to basically do the same thing. And I look back at the 13 years where I was chair, and I actually calculated that I received 15 emails per hour throughout the entire day. And I felt compelled to answer all the time. And that is so wrong. Just do not get into that sort of pattern where you feel compelled to be on this wheel where you're always trying to answer email or answer text messages right away. Enjoy your life. More than anything else, spend time with your family. Things can wait. Take care of your patients really, really well while you're working. Take time off. Go on vacation. I never went on a proper vacation with my family for 13 years when I was in Oregon, and that was immensely stupid. So take the time to spend with your family, your friends. Slow down is my best advice from a 30-year perspective.
I suppose they don't should take us as examples, because our life balance doesn't exist right now, and I think the technology will help us. But for sure, we should train the physicians and the medical staff technology, because we obtain much more advanced technology devices during our work. And we see that, for example, for sure, the oldest staff will have some problems, so we must focus on them and teach them. Because, for example, with Da Vinci, with the laparoscopy and other devices, the youngest are better than us, because they playing all the time with PlayStation or other devices, so they know how to use the manually and collect the manually with the screen. For example, when I start, the video laryngoscopy starts. So this was a big problem, for example, especially for the oldest anesthesiologist. Yeah, but now it's okay. But each device is different, so we need to teach how to use them, and this means we should teach the technology, because I suppose you told about us as we have the 100 years experience. So I think we are some kind of dinosaurs in the medicine, yeah, and the technology will help us, but the most important thing is the basic skills during the treatment. As I talked at my speech, of course we can use video laryngoscopies, but we should also know how to perform the direct laryngoscopy with the McIntosh or Miller blades. So if we know how to perform the basic skills, we can then upgrade our skills with the technology, not oppositive.
Yeah, thank you very much. I have a question for the audience. Is there anyone who doesn't like the technology? As you see, there's no one, because there is no need to hate the technology. We have to love it, and we have to marry with the technology and never divorce. Because it is mentioned, it makes our job very, very well. So far, we have to look in the patient from outside. But now we are inside. By the technology, we are inside. We can touch the organs by technology, by ultrasonography, and like this. Is it okay? No, it is not okay. A few years later, you will see, go through the tissue. You will see the tissue by technology. Is it lost? No, it is not. But a few years later, you are going through and see the cells, and then DNA. All this thing will happen in a very short time by the development of the technology. So regarding the teaching for the students and the residents, I think we have to give up the slides. There is no need to make intoxication, slide intoxication. There is no need. This is a slide intoxication. So we have to talk less and show more. But for the patient, we have to talk much more, because they are waiting. This is the thing they are waiting for from us. Let me repeat again. We have been looking from outside, now we are inside of the patients. But this is not the last step. We need to go through the organs and the tissue and the cells and DNA. All this will be happen. So as I always say, nobody hates technology. Technology also has some complications. It is a common thing, some complication. Now, talk less and show more. This is the unique thing that we have to do for our residents and our students, medical students. Thank you much.
So when we look at technology, yes, it is going to be there. I really like the punchline, let us slow down. Taking from that line, I would like to have your comments on the fundamental concept which has come up of digital detox.
Can I make just a small suggestion? We're almost, we only have a few minutes left. Perhaps we can open it up for the audience to start, because I think they might have some questions.
Thank you again. And it is our pleasure to hear you here again. And every single time when I hear you, I feel like, okay, someone actually understands us. And thank you for this again. And my question is, what's your resilience strategy? Because we've talked this in the first section, and I believe every single one has to have some resilience strategies. And what's your strategies for prevention of burnout?
Burnout.
So that is a fantastic question. And I think back, you know, when you talk about looking at yourself when you first started, I felt compelled to succeed at everything. And if I got a rejection of a manuscript, I was devastated, just absolutely devastated. I felt like I was a failure. If I you know, didn't get a grant, I thought that I must have done something horribly wrong in the way that I wrote it. And the resilience strategy that I've developed over time is the fact that failure is a part of life. Failure is a part of being a doctor. Failure is a part of success, because every time you fail, you learn something. I have learned not to take failure personally. It is not a comment about me. And, you know, I do like quotes from famous people. And Vince Lombardi, a famous baseball person in the United States, said, "It's not how many times you fall down, it's how many times you get up." And Winston Churchill said, "Never, never, 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 never quit." And so I think those things are really important. If I don't get a grant, if I get back a manuscript saying that it's rejected, this is not about me. This is part of the journey, that a lot of things that I do are going to be tremendously successful. A lot of things that I do are not going to succeed. But it's your overall contribution to emergency medicine that matters the most, not the individual little steps along the way. It's the journey. The other thing that I think is a resilience strategy that's been very successful for me is I don't compete against other people, ever. I compete against my own abilities. I truly, truly believe that there is room at the top for every single human being. You strive to be the top person that you are. What you were put on this earth to do, what you were born for, is what you're going to accomplish, and you're going to be the best at it. And I can never be John Ma. I'm not going to be the best John Ma. I'm not going to be the best Lukasz. I'm not going to be the best Sagar. I'm not going to be the best Beshet. I am going to be the best me. And if they are fantastic at everything that they do, if they are massively successful, my life is better, the universe is better. And so those are my two strategies. Number one, that failure is part of life, and it's what your ultimate contribution is, not each individual success or failure. And second is competing against my own ability, not against other people.
Thank you so much.
I would advise people to look at the big picture. I mean, we're all going to fail, as Lisa just pointed out, so we're going to get knocked down. But look at the big picture of how that one individual step will fit into the overall plan. So perhaps you get a paper rejected, or perhaps you don't get a grant funded, as Lisa pointed out, as good examples. What can you learn from that? Because in the big picture, that one thing might actually be the best thing that ever happened to you, because then you can go off into a different direction, take that feedback and move on and say, hey, I realize now that that direction was a dead end, but now I can look at a whole new path. So use every success, every failure in the big picture and stay focused on the end point.
In my perspective, maybe someone of you think this is trivial, but we should walk in our familiar neighborhood and avoid any conflicts, especially conflicts in our work. Because if we go with smile to the work, we are happy, and this is most important thing from my perspective. And of course, if we make something wrong. This also learn us something, but we should go forward and change our thinking, talking, and everything to be a better person next day and happy with life. Because if you are, for example, emergency physician, you should like this. This is your life, and you spend half life in the hospital. So if you like what you do, this is the best situation, because you never work, but you lived with a smile.
Yeah, that's so true.
Any other question from the audience? So, talking about burnout, one of the major things why does burnout happen? We talk about burnout a lot, but we don't see why does it happen, right? So, the fundamental of burnout revolves around a couple of things. You can never see burnout in the military. You don't see burnout in planes, because if they burn out, they lose the job or they have to retire. The problem in medicine, which I feel with burnout, is that there is no backup plan. So when we go into medicine, we do not have an exit strategy. Every fundamental business has an exit plan. We never design. We think that this is what we are going to do all our life. This is what we are here for. God gave us this opportunity. We are going to do everything alone. And that is a major mistake which is made all the time. There is no exit plan. So you burn out because you don't have any other thing to do. You just keep doing the same thing, and you do not have options, which is in your hand when you are young. So the core to this is that God gave us the opportunity to become doctors. He gave us the brain to study 40,000 pages. That doesn't mean He gave you the brain to only study one type of 40,000 pages. He also gave you the opportunity to study something new. So instead of doing just medicine, if you're thinking that you're burning out, go and learn a new skill, which is non-medicine. And maybe that will work. So when COVID happened, one of the core things which struck my mind was that, what should I do if medicine was not there? And one thing which I always wanted to do is business management. So I went back to school and I did an MBA in banking. I didn't do an MBA in hospital administration, healthcare, just kept it out. I went back, studied math, calculus, banking, financial management, bank strategies, marketing. I learned something totally new. It was hard. I didn't know derivatives, probability, I forgot all of that. I just forgot, and I went back to learning that. And I think it was the most rewarding experience of my life. And it changed me completely. Like, I started thinking very differently. I started approaching things very differently. So I think burnout is a myth. And it is a myth because we don't have solutions. It is a reality, but it's a myth because we do not design a strategy for burnout. And we focus on doing all our work in one specialty, one thing every day. Of course you're going to burn out. Of course you're going to burn out. So it's up to you how you're going to do that. And that's very important. Now, keeping that in mind, when you look at the new generation who talks about work-life balance, there is no such fundamental as work-life balance, because you have to work to live a life, and in life you need to work to survive. So if you try to do balance, you're going to compromise your luxuries, or you're going to, so it's never balance. It's always going to be up and down, up and down, up and down. So they'll also have to have options. And that is the reason I asked in the opening question, do we need technology training? And do we need something else? That's why we have schools now giving a law degree with medicine. We have schools which are giving a PhD with medicine, schools which are giving a MPH with medicine, schools which are giving an MBA with medicine. And soon I think they should have AI and medicine combined as two separate degrees, where computational biology, coding has to be taught to doctors. And I really think that helps, because if doctors have options, then it is better for doctors to think that I cannot do this, I will rather do that. keeping the fact, like yesterday, me and Dr. Ma had a very big conversation about portfolio management and how do we think about retirement strategies. And I learned so much in that half an hour with him. And that really opened my mind that should we train our students to know how to retire? That is never discussed. So I think there's a lot of things as a society of medicine, as such, as a community, we need to do. But really talking about it from a pessimistic view of burnout is not going to design the solutions, because you'll always try to blame the system for it. And I think that's not the way it works. The system is the system. You cannot change that for generations. You're not going to be able to. What you can change is the way you handle the system, the way you play in the system, and the way you find a solution to the system. And that's very important. If things don't work out, just walk away. It's okay if it doesn't work out, do something different. There's no such thing as failure, because every failure is an opportunity to succeed. So, there's no such thing as that. And failure is not dependent on one person, it's dependent on a system. Your paper getting rejected may not be you, maybe a guy who just fought with his wife in the morning and came back and didn't like your article and just read the first 5 lines and wrote whatever he wanted to or she wanted to. So, you don't know, just because it didn't work out. So, just move on and do things. But yes, I really think options is important, and doctors have to learn to know when to leave medicine at the right time. And they need to have options so that they can have the same life they had as a doctor with the same money through a different field. And that, I think, is the best solution for burnout.
If I can, I think another important thing is that we are specialists of the critical care and we treat those patients. But if we have first signs of the PTSD, don't be afraid, go to the specialist.
Seek to help.
Maybe not psychiatrist, but psychologist, and with them find some solution. What to do, what we like, maybe we should go to some kind of hobby or other.
Yeah, so, communication, which is important part. This whole generation and this technology has made us less and less talk to each other, communication going down, verbal communication is gone, everything is internet, and we just don't know how to talk, we just don't know how to express.
Thank you very much.
Yeah, you say it there after that. Yeah, you do your talk.
Burnouts, now everybody is talking about the burnout. It's not just for us. It is for all disciplines, all workplaces, in family, with children, everywhere, How can we struggle with it? I read a very good philosophy sentence from a famous man from India. He was one of the previous president of India. His name is Abdul Kalam. Maybe you know about him. He has very good suggestion for the burnout. This is not just for us. If you can change anything, do it. If you can, because the sources of the burnout is different. Something we can change, something you cannot change. It is related to the system. Can you change the system? If so, work at it. If not, there is no need to struggle with it. The second one is regulation. We have to regulate ourselves according to the evidence. If evidence change, our practice should be changed. This is for all time, not in clinic, outside and inside. Then, okay, we can get support from the psychiatric, that's okay, but it is not enough. We have to become our psychiatrist ourselves. We have to become, we need it every time because, and then, if you look at the life, you have a belief that it will be changed, will be better, it will be better. If you look at the life as it is going down, it will worse, it will worse. So we have changed our opinion also. And as I said, we have to become our psychiatrists ourselves. This is really, really very important. But otherwise, it is very difficult to come over it. Thank you.
Hello. I want to ask a question I think will combine two main components that we discussed right now. These two main components is technology, especially artificial intelligence and burnout. Because I want to ask that, do you think artificial intelligence can reduce burnout rates among emergency medicine physicians? Because in fact, my question depends on a new survey that we made. Because senior doctors sees artificial intelligence as a barrier to human touch, but junior physicians, emergency physicians, sees artificial intelligence as a prosthetic arm, prosthetic shield for the cognitive burden, cognitive jobs during the daily practice. So maybe in the upcoming days or decades, maybe artificial intelligence can reduce the burnout rate because it will decrease the cognitive burden. And what do you think about that?
What do you think?
So I think that's a fascinating question and an interesting concept, because when you think about what causes burnout, so there are many people who say that burnout is caused by a loss of agency and a sensation that what I do doesn't make a difference. And if you take it with that definition, artificial intelligence might actually increase burnout, because if you have AI telling you what to do, you don't have agency. You're not doing what you think the patient needs. You're doing what someone else is telling you to do. So is that any different than having a non-physician CEO telling you what to do, or a corporate medical group telling you what to do? I don't know. And so the fact that I don't feel that I make a difference in a patient's life because I'm not the one making the decisions. So on that hand, it might increase burnout. On the other hand, artificial intelligence, with its ability to synthesize a tremendous amount of data that I don't have time to read all of that data, may actually give me a better solution for caring for a patient, which may make me feel more efficient at my job, more successful at my job, more informed in terms of what I can offer a patient in terms of treatment methods, which would make me less burned out. So I think there's two sides to it.
On the surface, I think AI will help improve things. One big example would be documentation. So I'm very, very compulsive about documentation. After a shift, in America, we only work 8-hour shifts, unlike physicians in Europe who work 12 to 24-hour shifts. But even after an 8-hour shift, it would take me 3 hours to sit down and type out and document everything, because I was very compulsive about having the next physician read my note and know exactly, step by step, what happened to their patient in the emergency department. And so I would go through my 20-something, 30 patients and document for hours and hours. Now we have AI apps that can distill all that information down and help people leave within 30 minutes with better documentation than I was able to do myself. So for me, documentation was one source of my burnout, and I think AI will definitely help in that aspect, along with synthesizing other data and things like that. Ultimately, though, people are going to burn out regardless of AI. I think it's a whole different independent type thing. AI can make things simple. We're still going to find some way to burn out because of something else. So ultimately, you still have to find your resilience, whatever it takes, prayer, getting away from work with your family, your pets, hardcore drugs and alcohol. I don't know what it is, but something that will help you prevent burnout, because I think AI will just be that one independent variable.
On the topic, there are psychedelics right now. Yeah, but I fully agree, but the AI has two sides of the medals. because firstly it helps us with the, for example, documentation, but the second thing is that we focus on it, we don't thinking as much, and after then, if something go wrong, we have the worst issues by self. And the second thing is that something about which we don't talking about, I mean the legal issues of the using AI and the perspectives who should be responsible for the using AI and for the decision making. Yeah, because we as a doctors normally decide if something go wrong, we have the problems. But if we use AI, should I as a doctor be responsible, the director who give us the AI in the hospital, or the manufacturer which create or the government? So this is also problematic.
Right.
Thank you very much. Yesterday we had Google. Today we have AI. Tomorrow we will have AI, and the next day will be XA. So everything will be changed. I think the AI and the next day that's coming will not become our doctors. This is different. They've made our job very easy. That's the thing we are looking. So there is no any way to escape from them. We have to update our mentality and behavior accordingly. These are not the doctors to treat your mind, but they make our job very easy. The mentality is different. We have to become our doctors. Let me give an example. When you think about that, there is a very rich man goes to a very good restaurant and have more than 10 different kinds of the meals and things. And in the other side, there is a very, poor people just eating piece of the bread. He get much more delicious than this one. This is not relation about the kind of eating. So this is like the technology. Technology is your assistant. Should become just your assistant, not a doctor to treat your mentality, your psychology, and like this. So, but we can change our living, according to the practice. Thank you very much.
So, as we summarize this session, we looked upon multiple things. We talked about technology, we talked about AI and its future. AI dominated the discussion, technology dominated the discussion. We talked about ways to tackle burnout and whether burnout was related to technology. We talked about options. We talked about how we are stuck in one specialty or one profession and we don't think of any other option. So a very vibrant discussion around that. I would like to close this with one concept called digital detox. Digital detox is a concept in which you just stop and move away from technology and take your own time to rejuvenate yourself and just do nothing. It's got a very scientific name about it. I was reading about it the other day, and it's something like you just, in various cultures, somewhere in India it's called Vipassana, somewhere it's called just silence therapy. But digital detox is, I think, the future where we'll have to look at just disconnecting and rebooting ourselves for the future. So thank you very much everybody for this fantastic discussion, and I'm very thankful to the audience to be here with this very different kind of panel which we have introduced this year, and we'd like to carry it next year to make it more and more vibrant. Thank you very much to be a part of this inaugural panel. Thank you very much.
Thank you.
And see you in the evening.